All right, the last component of CVP, SCVO2, and the whole sepsis bundle is your central line and the use of SCVO2. SCVO2, what is that? Saturation of central venous oxygenation. So basically what you're monitoring here is the amount of oxygen saturation right here at this distal end. And you guys remember where this distal end is? It's located right there. When it's placed in by the doctor, it's going to be sitting right there at the superior vena cava. All right, superior vena cava. So basically, the saturation of oxygen at this point right here should be between 60 and 80%. All right, 60 to 80%. Saturation right here, when you put your SpO2 monitor on, is what, 99, 100%. Now, once blood has dropped off all its oxygen to all the organs, all the tissue, it's coming back to the heart for a refill. So that's what we're measuring: how much blood or how much oxygen is in the blood at this level right here. All right. So that's what this machine is going to measure. The amount of what percentage of blood, or what percent of oxygen is still at that blood. Alright, so basically, let's go ahead and turn this thing on. This is your Edwards Lifescience Vigileo. Alright, it's going to go through a series of calibration. Alright, it might be difficult to see because of the glare. I don't know if you can see it there. But I want to show you this, while it's doing that calibration, I want to show you the three different ports on this. This is your triple lumen catheter. Alright. There are three ports: your distal, your proximal, and your medial. Where you want your central line, the setup that we had earlier, you want that right there at your distal. All right? So this piece right here is going to connect to our Vigileo, and that's going to monitor, that's going to measure the amount of saturation right here at that distal end. So what we're going to do right here, some simple things here. The first thing you want to do is go ahead and hit continue, and it'll bring you to this main page right here. Okay, you can see even right up here at the top, SCVO2, and there's a roller wheel right here. Once you get it to SCVO2, okay, just go ahead and click it. Then it's going to ask you in vivo or in vitro calibration. All right, you guys remember what it was? Remember, Bridget, what it was?
The numbers?
In vivo.
Oh, I thought you were meaning like the plug-in that hemoglobin and hematocrit.
Sure, we'll get to that point in just a second. So in vivo calibration. So this is where the doctor already has placed this in. It's already in the patient. We're going to use in vivo calibration. In vitro calibration can be used if this is still in the box and it's already connected. It's not the most practical thing in our setting, but usually most nurses over here use in vivo calibration. All right, so once you have in vivo calibration, what you're going to do is, let's go ahead and plug this in. Okay, hit in vivo calibration. All right, it's going to do a little self-test once again. You're going to see in just a second. I don't know if you can get a good screenshot of this, but you see that red dot at the end? All right, it's kind of like that red dot at your fingertip for these Masimo pulse oximeters, right? So that's exactly what, that's the exact same thing. You're measuring the amount of oxygen in the blood at this point right here. You guys remember where this point is at? Superior vena cava. Okay, superior vena cava. All right, in vivo calibration. Good. In vivo calibration. It's going to ask you to draw labs. All right, so you're going to draw your labs and use the iStat to get your basic labs such as H&H. That's pretty much what you need. H&H and your SaO2. SaO2. SaO2, saturation of arterial oxygen. That's how much oxygen. Yeah, it's how much oxygen that's in the blood at that time. So let's look at it this way. In a post-apocalyptic world where, let's say, you don't have this, or let's say for some reason you have 3 septic patients. 2 of these are being used, and we only have 2 of these in our entire department. So that third patient, if you don't have this and you want to know your SCVO2, just run an iStat, all right, and get your SaO2 level. Your SaO2 corresponds identically with your SCVO2. So in theory, you can just go ahead and keep drawing SaO2s every hour and monitor, and that's considered monitoring your SCVO2 levels. Okay.
I didn't know.
Yeah. If you do have 3 patients and you only have 2 of these. All right. So we draw that, and you get over here. It's going to ask for your SCVO2. Well, gee, isn't that what we're trying to monitor? In fact, like I mentioned earlier, it's your SaO2. All right. That number should be between, once again, 60 to 80. So I'm going to go ahead and leave it at 75. Let's put some hemoglobin numbers. Let's leave all those numbers the same. Hemoglobin and hematocrit, those are numbers you're going to get from your iStat. Okay, you'll get those in a couple minutes. Lastly, hit calibrate. And that's pretty much all there is to it. All right. Once you hit calibrate, that's it. So at that point, you're going to see it on the monitor the trends. Okay, over time, what is your oxygen saturation right here at this distal end? Now keep in mind, this does not talk to this. All right, to this monitor. Meaning everything you did with data validating, with your map, your CVP, your blood pressure, your hemodynamics, all that good stuff, that can be data validated. SCVO2 has to be manually inputted. All right. So, all right. Let me finish this up right here. So, lastly, the key things that will change your SCVO2. Remember, at this level, it should be 75, meaning blood has dropped off 25% oxygen. Now it's coming back to get a refill at the heart. Make sense? Mm-hmm. So why would this number be 95, 96, 97%?
Because it's already dumped off its oxygen.
Right? Not that, not necessarily. It could be one of two reasons. One, the patient is dead. No, not dead, but the patient is in severe sepsis, late sepsis at that point, where the blood is being dropped off to the tissue, oxygen is being dropped off in the tissue, but the tissue is so septic, so dead at that point, where the tissue is just not taking up that oxygen. So that's why blood comes back to the heart fully oxygenated, because the tissue is saying, I'm so dead, I can't take it. I don't have the strength to take the oxygen that's being delivered to me. Therefore, blood returns back to the heart fully oxygenated. Or two, what if the patient is intubated, sedated, so zero metabolic oxygen demands, intubated and receiving 100% oxygen? Then blood will come back here 100% oxygenated, or really highly oxygenated. Not too much of a concern. Where we're concerned with in sepsis is when this number is below 65 or below 70. All right? 4 main reasons why this patient will be below 70. All right? Let's think about it. Cardiac output. Let's start off with cardiac output. If we're not getting enough oomph out of that heart to deliver this oxygenated blood in our heart to the entire body or to the tissue, then blood will return back to this distal end deoxygenated. Okay, less saturation. Secondly, what about hemoglobin, hematocrit? Why is that important? What if you don't have enough oxygen carrying cells to deliver to the tissue? Blood, once again, will return back to this heart, will return back to the heart desaturated. Right? 2 more things. What if in severe sepsis, and this is pertinent to the bundle completion, in severe sepsis where the tissues are starving, they're dying, lactic acid is building up, all right? What we're doing right here, now the heart is delivering, the heart is pumping blood, oxygenated blood to this tissue, all right? And what's the tissue doing? It's trying to suck up as much blood as it can, or suck up as much oxygen as it can. So it's just taking up as much oxygen that's being delivered to it. Therefore, when blood comes back to the heart, its oxygen saturation is like 30, 40%. Why is that? Because the tissue is starving for oxygen and is trying to take up as much oxygen that's being delivered to it. All right. Keep in mind, once again, the range we want is 65 to 85, roughly about 70. All right. But if it's coming back at 30 or 40, we're in severe sepsis right here, where the tissue is in that dying process right now, and it's trying to get as much oxygen as it can. Lastly, the last reason why this number would be about 30 to 40% is because there might be some respiratory ailment that's causing the lack. There's a lack of oxygen getting to the tissue in the first place because of a respiratory problem.
Especially if they're intubated too, or something. Well,
Or if they're intubated, they're getting 100%. But if they have some type of respiratory problem that you're not getting enough oxygen delivery to the lungs, into the blood, then yes, we're not delivering enough oxygen to the tissues in the first place, because we're not getting enough oxygen in the blood in the first place. Make sense? So recap of the 4 reasons. Cardiac output, we're not getting enough oomph out of that heart. Secondly, what did I say earlier? Cardiac output, hemoglobin, hematocrit, we don't have enough blood getting to the tissue. Okay, so not enough oxygen is getting tissue. Thirdly,
Severe
severe
sepsis.
sepsis, where the tissue is dying, where it's at that dying point, where it's trying to suck up as much oxygen as it can. And lastly, if there's some type of respiratory problem that's preventing the delivery of oxygen to the tissue. Make sense?
Mm-hmm.
So remember, now in order to fix that, that's why we have the sepsis bundle. As you know, sepsis bundle, if your MAP drops below 65, quick review of what we spoke about a few minutes ago. So your MAP, what's your MAP? Mean arterial pressure? Yep. So it's basically, if we're not getting enough it's basically the amount of pressure that your end organs are seeing. We're not getting if we're not maintaining a MAP of 65, we're not getting enough perfusion to our end organs. Hence, you'll have multi-organ death syndrome. All right, that increases your chance of mortality when multiple organs start dying. All right, so that's why with MAP, drug of choice was what, Vanessa?
Norepi.
Norepi. We want to get some norepi in there. Norepi, oomph, get more oomph out of that heart. All right. 2 doses of norepi, you got your beta dosage, but we're predominantly using it for its alpha dose. All right, getting enough blood from your periphery and just shunting it to your heart, okay, to get more oomph out of that heart. And lastly, SCVO2. According to the bundle, if your SCVO2, if your H&H is low, how do we address that?
Transfuse.
Transfuse some blood. All right. What if their H&H is fine? H&H is fine. Well, remember the other things I was mentioning? What if we're not getting enough oomph out of that heart? We're not getting enough.
Pressors.
Not pressors. Close. We're the pressor of choice, or the inotrope of choice, is dobutamine. Guys, remember what dobutamine is? You're a student, Vanessa. What's dobutamine? Put you on the spot here. It's a pressor. It's an inotrope in particular, but predominantly it has beta 1, beta 2 properties. So beta 1, it gets more contractility of the heart. But what it also does not do, it has a positive inotropic effect, but it doesn't have any chronotropic effects. All right. So dobutamine is your drug of choice for cardiac output. The reason why we also have norepi on there as opposed to dopamine, we have 2 drugs in here. We have a couple inotropes in there. We have your norepi. We also have dopamine in there. Both of them are readily prepackaged. Norepi is your drug of choice because what it does, it keeps perfusion to the gut through the splanchnic artery. All right, so we want perfusion to the gut. All right, dopamine, it has the same pressing effect, but it cuts off circulation to the gut. And once you start doing that, once again, it revolves around multi-organ death syndrome mods. All right, so Levophed, norepi is your drug of choice. All right, and once again, Levophed over dopamine is predominantly used for its alpha properties. Dopamine is predominantly a beta with some alpha properties as well, but norepi, on the other hand, is an alpha. It's a pure alpha at high doses greater than 10 mics per kilo per minute. It's used for its alpha properties. All right? Any questions?
Cool.
Cool.